Welcome everyone to vpod.ai. Today we're embarking on a deeply important journey, a deep dive into a topic that touches millions globally, cervical cancer. Before we begin, we just want to acknowledge that this deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, which is a turnkey security appliance, and also public and private cloud solutions. You can check out stonefly.com for more information. So our mission today is really to equip you with a thorough understanding of cervical cancer. What it is, how it's caused, the incredible strides being made in its prevention and treatment, and also the often overlooked challenges and disparities that, well, they still exist. We're here to extract the most crucial insights and surprising facts, helping you feel truly well informed on a topic that has such profound human impact.
Indeed. And this isn't merely about dissecting a medical condition. It's really about grasping a global health challenge that, astonishingly, is largely preventable.
Yeah.
We'll try to connect the dots between, groundbreaking research, public health initiatives, and the very real human experience of those affected, offering, hopefully, a truly comprehensive perspective for you.
Okay, so to really understand the scope of this challenge, let's start with the fundamentals. When we talk about cervical cancer, what exactly are we defining?
Right. So it's a cancer that begins in the cervix. That's a crucial part of the female anatomy, basically connecting the vagina to the uterus. Like any cancer, it's characterized by the uncontrolled abnormal growth of cells. And these cells gain the ability to invade surrounding tissues or even spread to distant parts of the body.
And its global footprint is, well, it's truly staggering, isn't it?
It really is. Cervical cancer holds the, well, unenviable position of being the fourth most prevalent cancer among women worldwide. The numbers from global health organizations are quite sobering. In 2020 alone, over 604,000 women were diagnosed. Even more tragically, it's responsible for more than 341,000 deaths annually.
Wow.
That translates to a life claimed by cervical cancer every 2 minutes, somewhere in the world.
Every 2 minutes. That statistic just, it really underscores the urgency of this conversation. It's also the second most common female-specific cancer, right? Right after breast cancer?
That's correct. It accounts for roughly 8% of all cancer cases and deaths in women.
Mhm.
But what really highlights the global health inequity here is that about 80% of all cervical cancer cases occur in developing countries.
80%. That's a massive, disproportionate burden on communities with fewer resources.
It is. And the survival rates grimly reflect that disparity. If you consider India, for instance, the 5-year relative survival rate hovers around 46%. Now, compare that to other Asian nations where access to screening and treatment might be more robust. The contrast is stark. This isn't simply a medical issue. It's a profound public health, economic, and social challenge that demands our attention, especially for women in resource-limited settings.
So now that we've grasped the scale of the challenge and what cervical cancer fundamentally is, the logical next step is to ask, why? Why does this devastating disease primarily occur? What's the main driver behind it?
The answer is remarkably clear and consistent across over 95% of all cervical cancer cases globally. It's the human papillomavirus, or HPV. This virus is the primary culprit driving the vast majority of cases.
And how exactly does HPV spread? Most people, I think, associate it with sexual transmission.
That's the most commonly reported mode, certainly. HPV predominantly spreads through direct skin-to-skin or skin-to-mucosal contact. And sexual contact is a very efficient way for that to happen, yeah. However, it's really crucial to understand that sexual transmission isn't the only pathway. Other non-sexual methods exist too. Things like horizontal transmission through skin contact, say between fingers and the mouth, can also occur. So this broadens our understanding of just how pervasive this virus can be in a population.
What's truly fascinating and maybe a bit unsettling is that most people don't even realize they've been infected.
Exactly. The body often clears HPV infections on its own, without any symptoms at all. But here's where the risk emerges. In about 10% of cases, the infection persists, doesn't clear. When that happens, particularly with what we call high-risk strains, the virus can actually transform normal cells into cancerous ones.
High-risk strains, like which ones specifically?
We're primarily talking about HPV 16 and 18. Those two strains are responsible for nearly half of all high-grade cervical precancers.
Okay. Which logically brings us to prevention. And one of the biggest breakthroughs there has to be the HPV vaccine.
Absolutely. It's one of the most significant breakthroughs in public health, really. The HPV vaccine is incredibly safe and highly effective at preventing cervical cancer. It's recommended for both girls and boys, ideally before they become sexually active. And for many years, the standard recommendation involved 2 doses,
But that recommendation has seen a truly game-changing shift recently, hasn't it?
It really has. The World Health Organization's Strategic Advisory Group of Experts on Immunization, they call it SAGE, they actually updated their guidance on HPV vaccination back in April 2022. And this shift was largely influenced by groundbreaking research, particularly from studies led by the International Agency for Research on Cancer, or IARC.
So what did that IRC research find that was so revolutionary?
Well, what's truly revolutionary here is that while earlier studies had kind of hinted that a single dose might be effective, IRC's larger, much more robust studies, they followed 15,000 girls for over a decade, provided really strong, irrefutable evidence. Their monumental finding was this: a single dose of the HPV vaccine provides a similarly high and long-lasting immune response and protection. Protection against persistent HPV-16 and HPV-18 infections that's comparable to what you'd see with 2 or even 3 doses.
Wow, just one dose.
Just one dose. And the strong antibody response they observed suggests this protection isn't likely to fade anytime soon. It seems really durable.
So what does this truly mean for the bigger picture, for global health? I mean, imagine a breakthrough that could revolutionize how we tackle a major cancer, potentially preventing millions of cases with just one simple action.
That's precisely what this IRC research revealed. And think about the cost effectiveness. A single dose schedule can slash the cost per person by a third, maybe even half. That frees up immense financial resources for policymakers, for governments, especially in low and middle income countries, LMICs, that often grapple with strained healthcare budgets.
Absolutely. And beyond just cost, it must simplify the logistics enormously.
Profoundly. Picture a vaccination program that no longer has that complex challenge of tracking down adolescents for a second dose.
Yeah.
Or one that's far more resilient if there are vaccine supply disruptions, which do happen. This single-dose approach makes vaccination programs significantly easier to implement. And that's a critical factor for success, particularly in LMICs where infrastructure can be a real barrier.
And the impact on overall access and coverage must be just monumental.
It really is. This simplified approach gives countries an unprecedented opportunity to dramatically expand the number of girls who can be vaccinated, which helps address the currently, pretty abysmal global coverage rate. It was only 15% for 2 doses back in 2021. It also makes things like multi-age catch-up vaccination campaigns feasible, and even the vaccination of boys becomes more achievable.
Which boosts that herd effect, right? Protecting the whole community.
Exactly, boosting the overall herd effect, further protecting everyone. And there's even more good news on the vaccine front. The development of new, affordable, quadrivalent HPV vaccines like Cervivac by the Serum Institute of India represents another huge step forward. These are expected to be much lower in price because of novel production systems, which should really accelerate cervical cancer elimination efforts, not just in India, but globally.
That sounds incredibly promising. Are there projections on the impact?
Yes. Mathematical modeling studies project that introducing a single-dose HPV vaccination program in India alone, just India, could prevent nearly 1 million cases of cervical cancer. That's over the lifetime of the birth cohort, currently aged 10 years or younger. It could potentially reduce incidence below the WHO's official elimination threshold.
That is incredibly hopeful news. It points towards a future where this preventable disease becomes, well, a rarity. Yet despite its proven effectiveness and these promising developments, vaccine introduction has been surprisingly slow sometimes, not just in LMICs, but even in some high-income countries. We've touched on cost and supply issues, tracking for second doses, but there's also the significant hurdle of vaccine hesitancy, right? Especially for this particular vaccine.
That's a critical challenge, yes. And it really speaks to public perception and misinformation sometimes. Some social conservatives, for instance, express concerns that the vaccine might encourage early sexual activity, although there's no evidence for that. Other parents simply fear that vaccines in general are somehow more dangerous than the diseases they prevent, which is also not supported by science. It's just so crucial to remember that the overarching goal here is purely public health. It's about preventing a deadly preventable disease. Full stop.
It truly is about saving lives. Okay, so beyond vaccination, what other prevention strategies should people be aware of?
Well, the correct use of condoms can certainly reduce the spread of HPV, though not eliminate the risk entirely since it spreads skin to skin. And interestingly, male circumcision can also play a role. It seems to reduce HPV transmission as the virus often attaches to cells inside the male foreskin. So circumcising males can lower the incidence of cervical cancer in their partners.
Interesting. Okay, shifting from prevention, let's turn our attention to early detection, which is equally critical because cervical cancer often presents with no symptoms in its early stages, right?
Exactly. This is precisely why regular screening is so vital. It catches potential issues before they become life-threatening. For decades, the Pap test, or Pap smear, has been the cornerstone of this screening. It's a simple medical test designed to detect abnormal cell growth in the cervix, and its widespread use has been remarkably successful. It's contributed to basically halving cervical cancer rates in places where it's common.
Having the rates, that's significant.
Hugely significant. And alongside the Pap test, a newer option has emerged, a test that directly checks for the HPV virus itself. This HPV test can often be done concurrently with a Pap test, or sometimes even replaces it in certain guidelines. And it may actually be even more effective at identifying who is at higher risk for cervical cancer.
So what are the current recommendations in the U.S., for example?
Well, current recommendations in the U.S. generally suggest a Pap test every 3 years for women aged 21 to 65, or after age 30, you might have a high-risk HPV test every 5 years, or often both tests together, co-testing every 5 years. The American Cancer Society, for instance, recommends both Pap and HPV tests for most age groups, regardless of your HPV vaccination status.
So even if you're vaccinated, screening remains important. That's a key takeaway.
Absolutely critical. Vaccination prevents most infections, but not all, and screening catches issues that might develop. And this brings us to a really exciting development that promises to dramatically expand accessibility to screening. The U.S. Food and Drug Administration, the FDA, approved self-collected human papillomavirus testing as an alternative method for cervical cancer screening. That was on May 17, 2024.
Self-collected testing. Okay.
Yes. And building on that, the first ever guidelines to incorporate this option into clinical practice were released just this year, on February 24, 2025.
So how does the self-collection work right now? Can you just do it at home?
Not quite yet for routine screening, though that's the hope for the future. Currently, the FDA approval specifies that self-collection is performed in a controlled medical setting. So typically in a doctor's office or maybe a clinic or lab setting, the patient collects the sample themselves using a specific kit, and then it's processed.
Okay. And what happens with the results?
Well, if the results are negative for high-risk HPV, which happens in about 90% of cases, the recommendation is usually to retest in 3 years. If it's positive for HPV 16 or 18, remember those are the most aggressive types, then a direct biopsy, usually a colposcopy, is recommended to investigate further. And if it's positive for other lower-risk, high-risk genotypes like HPV 56, 59, or 66, a repeat test in 1 year might be advised, or sometimes still colposcopy depending on specifics.
The immense benefits of self-collection seem pretty clear, right? Why is this approach potentially so transformative?
Its potential to dramatically expand access to life-saving screening simply cannot be overstated. It's huge. Think about patients who might prefer not to have a speculum exam for various reasons. Or maybe their primary care physician doesn't routinely conduct pelvic exams. This offers them an alternative. And beyond individual comfort, this method can also help alleviate patient backlogs at hospitals and healthcare centers, which is particularly crucial during times like now, when there are primary care provider shortages in many areas.
And while it's currently restricted to medical settings, you mentioned the future implications, at-home testing.
Exactly. The potential future for FDA-approved at-home self-collection for routine screening is incredibly promising. Imagine eliminating the need for transportation to a clinic, minimizing language barriers if instructions are multilingual, accommodating busy work schedules, and perhaps most profoundly, neutralizing the fear, embarrassment, or stigma that many women unfortunately still feel about gynecological appointments. Experts are increasingly vocal about this. If we can get everyone screened effectively, we can truly make cervical cancer a rare disease.
That's a powerful vision. Are there situations where self-collection isn't the right approach?
Yes, that's an important point. Self-collection isn't recommended for everyone. It's generally not advised for those experiencing symptoms like abnormal bleeding or discharge, or for individuals on immune-suppressing medication, as their risk profile is different, and also not for those who've had recent abnormal HPV or Pap test results that require specific follow-up. In those instances, a traditional clinician-performed examination remains medically necessary.
Got it. Okay, let's shift our focus now from prevention and detection to treatment and the hopeful breakthroughs that are emerging there. Conventional treatment approaches for cervical cancer are, like most cancers, highly individualized, right? Tailored to the patient.
Exactly. It depends heavily on the stage of the cancer, first and foremost, but also patient preferences, their overall health, future fertility desires, things like that. For early-stage cervical cancer, caught very early, surgery is typically the first line of treatment, often curative on its own.
And for more advanced stages?
Then chemotherapy and radiotherapy become the mainstays, often used in combination chemoradiation or CRT for greater efficacy. Immunotherapy is also gaining ground. It's sometimes employed, particularly if the cancer recurs after initial treatment.
And what about fertility? That must be a huge concern for many younger women diagnosed.
It absolutely is, and it's something oncologists discuss carefully. Advances in treatment mean there are sometimes options that can preserve the uterus and ovaries, allowing for future pregnancy. Though, unfortunately, larger or higher-risk cancers may necessitate treatments like hysterectomy or pelvic radiation that do prevent future pregnancies. It's a difficult reality for some.
But let's talk about a truly monumental leap forward that offers immense hope. The Interlace trial. Results published by Cancer Research UK in October 2024. You said this represents the biggest improvement in cervical cancer treatment in over 2 decades. That's a huge claim.
It is, and the data backs it up. It's not just an incremental step, it's a dramatic shift in patient outcomes based on a relatively simple idea. The Interlace trial investigated a new approach, basically changing the timing of treatment. They gave patients a short course, just 6 weeks, of what's called induction chemotherapy, before patients started the standard chemoradiation, the CRT.
So just adding a chemo phase beforehand.
Exactly, a preparatory phase of chemo. This subtle change in timing proved to be exceptionally powerful.
And the results are what make this so profoundly impactful.
Absolutely. This seemingly simple sequencing change delivered an astonishing 40% reduction in the risk of death, 40%, and a 35% reduction in the risk of the cancer returning or relapsing. To put that into real terms for patients, after 5 years, a remarkable 80% of trial participants who got this induction chemotherapy followed by CRT were alive, and 73% had not seen their cancer return or spread.
Okay, compare that to the standard treatment group.
In the group that only received standard CRT, 72% were alive at 5 years, and 64% were without recurrence or spread. So, you see, that's a significant improvement in both overall survival and keeping the cancer away. A real leap.
And what makes this particularly exciting is the accessibility of this approach.
That's the beauty of it.
Yeah.
The 2 chemotherapy drugs used for this induction treatment, they're standard drugs, carboplatin and paclitaxel. They are not new or experimental. They are inexpensive, widely accessible globally, and already approved for various uses. This means this newly validated approach could, theoretically, become a new standard of care relatively quickly, making a global impact without the long wait and high cost often associated with brand-new drug development.
That really makes you wonder, could this timing is everything strategy work elsewhere?
It's a fascinating question, isn't it? Could delivering additional rounds of chemotherapy or maybe other therapies before standard treatments like surgery or radiotherapy lead to similar breakthroughs for other types of cancer? It certainly offers a potential new paradigm for treatment sequencing across oncology that researchers are likely exploring right now.
While these treatment advancements are life-saving and offer immense hope, it's also crucial we talk about the other side of the coin, the adverse effects from treatment. Because cancer treatments, well, they can be tough on the body.
They absolutely can be. By their very nature, treatments designed to kill cancer cells can also damage healthy tissues and organs. These effects, or AEs, can vary significantly among individuals. They depend heavily on the specific type of treatment surgery, radiation, chemo, immunotherapy, and the doses used. A large observational study conducted in India, which involved over 1,000 women with cervical cancer. Their mean age was around 49, shed some light on this. It found that the age group of 36 to 50 years actually reported the most adverse effects, interestingly.
And did the study link specific treatments to more side effects?
Yes, it did. What was particularly striking is that the study revealed combined radiation therapy and chemotherapy, that CRT we just discussed, was the type of treatment associated with the highest percentage of adverse effects. It impacted over half the patients, 56%. And on average, a substantial 70% of women in the study experienced between 2 and 4 distinct adverse effects from their different cancer treatments. That underscores the broad impact on their well-being.
Let's break that down a bit. Which key organ systems were most commonly affected? That helps us understand the real patient experience.
Okay. The gastrointestinal system was overwhelmingly impacted, affecting a staggering 92.5% of patients in that study. We're talking about persistent, often debilitating issues like nausea that was reported by 19%. Radiation enteritis, which is inflammation of the bowel, affected 17%. Emesis, or vomiting, 16%. And diarrhea, almost 15%. And pelvic radiation disease specifically can cause chronic long-term issues like ongoing diarrhea, rectal bleeding, and something called tenesmus, that distressing sensation of needing to empty the bowels but not being able to. These things significantly disrupt a patient's daily life and overall quality of living.
That sounds incredibly difficult. What about other systems, neurological effects?
Moving to the neurological system, adverse effects were observed in over three-quarters of patients, 78.5%. Pain was the most frequently reported neurological issue, affecting over 35%, followed by profound weakness or fatigue, called asthenia, in about 21%, and insomnia in almost 11%. These symptoms can emerge soon after treatment starts, but unfortunately they can also persist long-term, including things like peripheral neuropathy, the tingling, numbness, or pain in the hands and feet.
And the skin, dermatological effects.
The dermatological system, yes, our skin, was also heavily affected. AEs were seen in 73.3% of patients. Common issues included hyperpigmentation, darkening of the skin in about 32%, dermatitis or skin inflammation in nearly 24%, and pruritus, which is severe itching, in over 18%. These skin changes might sound minor, but they can be significant enough to sometimes necessitate dose reductions or even delays in radiation or chemotherapy treatment. And of course, any delay can potentially impact both patient survival and their quality of life.
And finally, the genitourinary system. Given the location of the cancer, that must be affected too.
Absolutely. That system, which is directly in the area being treated, showed adverse effects in 71% of patients. Common issues here included things like vaginosis, changes in vaginal discharge or leukorrhea, and dysuria, which is painful urination. Pelvic radiation in particular can have a persistent negative impact on female sexual functioning. This could lead to really distressing symptoms like vaginal dryness, dyspareunia or painful intercourse, vaginal stenosis, which is tightening or shortening of the vagina, loss of libido, and difficulty with orgasm. These are major quality of life issues.
And reinforcing that earlier point about combined therapy.
Yes, the correlation with treatment types was quite clear in the study. Combined radiation therapy and chemotherapy, that's CRT, consistently showed the highest percentage of adverse effects across all these major organ systems. Over 58% for gastrointestinal issues, over 60% for neurological, over 61% for dermatological, and almost 66% for genitourinary effects were linked to CRT. It really highlights the particular challenges of these intensive combination therapies, even as they are often the most effective approach for fighting the cancer itself. It's a difficult balance.
Okay, let's pivot now to unpack the significant disparities and economic burdens associated with cervical cancer. These seem deeply intertwined with socioeconomic factors.
They absolutely are. That same Indian study we just discussed powerfully illustrated this connection. It revealed that over 78% of the patients in the study did not work outside the home, and a substantial 44.5% had monthly family incomes between roughly $200 and $500 USD, which is pretty low. This data starkly reinforces how economic and social conditions profoundly influence both timely diagnosis and, crucially, access to vital care.
And this isn't solely a problem in developing countries, is it? These disparities persist even in places like the U.S.
Unfortunately, yes. Despite the widespread availability of Pap tests and HPV vaccination in the U.S., the reality is that over 14,000 women are still diagnosed and over 4,000 die from cervical cancer annually. And incidence rates are consistently highest among Black and Hispanic women, as well as among low-income and rural populations. It highlights persistent and troubling disparities even within a high-income nation with advanced health care.
Let's delve into those racial and ethnic gaps further. The numbers are quite shocking.
They are. Hispanic women are 30% more likely to die of cervical cancer than non-Hispanic white women, and Black women face an even more staggering 65% higher likelihood of death compared to white women. A critical indicator of systemic failures is when they are diagnosed. Black and Hispanic women are significantly more likely to be diagnosed at later, regional, or distant stages. That signals potential failures in screening programs reaching them effectively, or delays in follow-up after an abnormal screen.
So it's not just about incidence, it's about later diagnosis leading to worse outcomes.
Precisely. And these systemic barriers seem so entrenched that even living in an urban setting doesn't appear to offer much protection for Black and Hispanic women. They often face similar access issues and delays in care as women living in more remote rural areas.
This raises a deeply uncomfortable but necessary question. Are there implicit biases within the healthcare system affecting follow-up care?
The data is certainly troubling and suggests potential issues. For example, some studies show Black women are actually more likely to be screened initially, but then they're less likely to receive timely or appropriate follow-up recommendations after an abnormal Pap result. One study cited 78% follow-up recommendation for Black women versus 87% for white women. It forces us to ask difficult questions about whether providers are, perhaps unconsciously, working harder or differently to ensure white women return for necessary treatment compared to women of color.
Is there also a biological component being discussed, or is it purely systemic?
It's complex, and researchers are looking at multiple factors. There are some studies suggesting potential biological differences. For instance, some data indicates black women may take longer to clear certain HPV infections naturally, and they might be slightly more susceptible to some high-risk HPV strains that aren't as well covered by the current primary vaccines. Also, when infected with HPV-16, their viral genome might be more likely to integrate into their own cellular DNA, which is considered a key step towards cancer development. Furthermore, there's growing understanding of how chronic stress potentially resulting from experiences of racial prejudice, socioeconomic hardship, or environmental factors like pollution can suppress the immune system. And that could affect both the body's ability to clear HPV infections and its response to cancer treatment if it develops.
And this seems like a crucial budge. How much do these potential biological factors matter compared to access to care?
That's the critical point. Studies consistently show that when you control for other factors, meaning when women are the same age at diagnosis, have the exact same cancer stage, and crucially receive the same quality and standard of care, there's generally no significant race-based difference in mortality outcomes.
So equal care equals equal outcomes, largely.
Exactly. This strongly indicates that the disparities we see are primarily driven by human choices, systemic issues within healthcare and society, and unequal access, not by inherent biological differences tied to race. The issue appears fundamentally rooted in achieving equitable access to screening, timely diagnosis, and high-quality treatment for everyone.
This brings us to specific barriers in treatment access and the economic hardship.
Yes. For instance, looking at treatment patterns, some data suggests black women are more likely than white women to receive chemotherapy or radiation for early-stage cervical cancer. Instead of receiving a hysterectomy, which is generally considered the standard, often curative treatment for that stage, why that difference exists needs more investigation, but it points to potential inequities in treatment offered or accessed.
And then there's a specific type of radiation, brachytherapy.
Right, brachytherapy. This is internal radiation delivered directly to the tumor. It requires high expertise and specialized facilities. It significantly improves tumor remission and survival rates, especially for locally advanced cervical cancer. Yet, studies show black women are demonstrably less likely to receive brachytherapy, despite its proven effectiveness for all stages where it's indicated. And without brachytherapy, survival for locally advanced cervical cancer is severely compromised. This isn't a minor difference, it's a major gap in accessing potentially life-saving treatment.
And the socioeconomic challenges underpinning this are huge.
Undeniable and often overwhelming. We mentioned the poverty statistics earlier, disproportionately affecting Hispanic and Black populations in the U.S. This translates directly into immense difficulties with practical things: taking time off work for appointments or recovery, affording transportation, arranging childcare, covering co-pays and other direct medical costs. That study in Uganda really brought this home. It showed women from lower socioeconomic groups were significantly more likely to have to borrow money or even sell possessions just to afford care. The burden even extends to unpaid labor, like having to decrease the time they spend caring for their own children because of treatment demands and costs.
Are there other non-economic barriers at play?
Definitely. Language and cultural barriers can be significant hurdles for Hispanic women, for example, hindering them from seeking care initially or fully understanding complex diagnoses and treatment plans once they do. And among Black Americans, as we touched upon, there's often a deep-seated, generations-long mistrust in the medical community. This stems from a painful history of mistreatment and unethical experimentation, like the infamous J. Marion Sims' surgeries on enslaved women without anesthesia. This historical trauma isn't just history. It continues to impact present-day engagement with the healthcare system and shapes health decisions for many. Given all these complex barriers, what are some potential solutions? How can we start to dismantle these disparities? Well, there are several promising approaches. Patient navigators, individuals who help guide patients through the complex healthcare system, can be incredibly instrumental. They help overcome logistical hurdles like appointment scheduling, transportation, understanding insurance, filling out paperwork. At-home self-sampling tests for HPV, which we discussed earlier, could be profoundly important for improving screening access, especially by neutralizing some of that fear, stigma, or practical barriers like travel associated with clinic visits.
Learning from other settings, too.
Yes, we can learn valuable lessons from innovations in low and middle-income countries. Things like community health workers providing door-to-door care or education, or programs offering transportation assistance. These could inform strategies for reaching underserved populations in rural or low-income areas here. And finally, policy matters. Increased health insurance availability, as demonstrated by the positive impact of the Affordable Care Act on improving early diagnosis rates for some cancers, is crucial for making screening and subsequent care more accessible and affordable.
Okay, moving on from the intense realities of diagnosis, treatment, and disparities, let's talk about life beyond cancer, the journey of survivorship and focusing on long-term health.
Right. Completing treatment is naturally a monumental relief for most survivors, but it's often coupled with a significant amount of anxiety. The worry about the cancer coming back or recurrence is incredibly common and understandable. And for some individuals, the cancer may never fully disappear. They might require ongoing treatments to manage and control it, which turns cancer into more of a chronic condition. That can be an immensely stressful and continuous battle.
So follow-up care is absolutely critical in this phase.
Paramount. Regular follow-up appointments are vital. These usually include physical exams, sometimes imaging tests like CT scans or PE scans, and blood tests. They're designed to watch carefully for any signs of recurrence, but also to monitor for potential long-term side effects from the treatment itself. Even after a hysterectomy where the cervix is removed, regular Pap tests of the vaginal cuff, the upper part of the vagina, are typically still recommended for surveillance. And importantly, survivors should also diligently adhere to the general cancer screening guidelines for other cancers, like mammograms for breast cancer or colonoscopies for colorectal cancer, as their overall risk profile needs continued monitoring. You mentioned a survivorship care plan. What does that involve? It's really important for survivors to discuss creating a personalized survivorship care plan with their doctor or oncology team. This plan acts like a roadmap for life after treatment. It should ideally include a suggested schedule for all the necessary follow-up exams and tests, a comprehensive list of possible late or long-term side effects specific to their treatment so they know what to watch for, and practical advice on healthy behaviors, diet, exercise, smoking cessation that can improve their overall health and potentially lower the risk of recurrence or second cancers.
And managing those long-term side effects is a big part of survivorship.
A very significant part. Some effects from treatment, as we discussed earlier, like neuropathy or sexual dysfunction or bowel issues, can unfortunately linger for years. Or sometimes new side effects can even appear years after treatment has finished. These are called late effects. It's absolutely critical for survivors to report any new symptoms or problems to their doctor promptly. Don't just dismiss them. They could indicate a recurrence, but they could also signify a new, unrelated health issue that needs attention.
What about lifestyle? Adopting healthy behaviors after cancer, does that make a difference?
It's always a good idea, certainly for overall well-being. While more research is needed specifically on the direct impact on cervical cancer recurrence rates, a healthy lifestyle is undeniably beneficial for survivors. For example, some studies suggest that women who are more physically active after a cancer diagnosis might live longer. That's a powerful motivator.
And smoking?
Quitting smoking is absolutely crucial. Smoking is strongly linked to the risk of developing cervical cancer in the first place. And for survivors, quitting can improve their tolerance to any ongoing treatments, reduce recovery times, and significantly decrease their risk of developing other smoking-related cancers down the line, like lung or throat cancer.
What about diet and alcohol?
Following a healthy eating pattern is recommended, one that's rich in fruits, vegetables, and whole grains, and limiting red and processed meats, sugary drinks, and highly processed foods. This offers broad health benefits beyond just cancer. Limiting, or ideally avoiding, alcohol consumption is also generally recommended for cancer survivors.
And dietary supplements. Lots of people ask about those. Vitamins, herbs.
That's a common question. It's really important to be clear here. Currently, no dietary supplements, including vitamins, minerals, or herbal products, have been definitively proven in rigorous studies to clearly lower the risk of cervical cancer progressing or returning. Some might even interfere with medications or cause harm. So the advice is always discuss any supplements you're considering taking with your healthcare team first. Don't self-prescribe.
And the emotional side of survivorship. That must be huge.
Absolutely huge. The emotional toll of a cancer diagnosis and going through treatment cannot be overstated. It is entirely normal, expected, even for survivors to experience periods of depression, anxiety, fear, or ongoing worry. Seeking support is key. Talking to friends, family, leaning on religious or spiritual groups if that's helpful. Joining support groups with other cancer survivors who truly understand what you're going through can be incredibly beneficial. And consulting professional counselors or therapists who specialize in oncology can provide vital coping strategies. It's a journey that extends far beyond just the physical treatment.
And one final difficult point about survivorship, the risk of second cancers.
Yes, unfortunately, having had cervical cancer doesn't grant immunity from developing another unrelated cancer later in life. Survivors may actually be at a somewhat higher risk for certain types of second cancers. Many of these are linked to those same common risk factors, like smoking and HPV infection. Think cancers of the mouth and throat, larynx, anus, vulva, vagina, lung. Also, risks for certain other cancers like acute myeloid leukemia, AML, and cancers of the rectum, bladder, and even bone are specifically linked as potential late effects of pelvic radiation treatment itself.
So maintaining those healthy behaviors becomes even more important then.
Crucial. Maintaining healthy behaviors like avoiding tobacco, staying physically active, maintaining a healthy weight, and eating well are really important steps survivors can take, not just for overall health, but specifically to help lower the risk of developing these second cancers as well. It gives survivors some agency in managing their long-term health risks.
So after covering all this ground, what does it all mean? Where does this leave us? We've covered a lot today, haven't we? From the frankly shocking global statistics of cervical cancer to the incredible potential of innovations like the single-dose HPV vaccine and the promising new treatment strategies like that Interlace trial showing the power of induction chemotherapy. But we've also confronted the stark, persistent realities of disparities in care and explored the long, complex journey of survivorship.
What's truly fascinating, I think, is this powerful blend of incredible medical and scientific innovation happening alongside these enduring human and systemic challenges. We increasingly possess the tools, the knowledge, the technology to virtually eliminate cervical cancer as a major public health problem. We really do. Through vaccination, widespread and accessible screening, and highly effective treatments. Yet, as we've discussed in detail, systemic barriers, crushing economic burdens for many, historical mistrust, logistical hurdles, they all continue to hinder our progress. They prevent us from reaching everyone who desperately needs these life-saving interventions.
Which really leaves us with an important question for you, our listener, to reflect on. What concrete step can you take or perhaps advocate for in your community or sphere of influence to contribute to the goal of cervical cancer elimination? Maybe it's spreading accurate awareness about the safety and importance of the HPV vaccine for both boys and girls. Maybe it's supporting initiatives that actively work to address healthcare disparities and improve access for underserved populations. Or maybe it's something as simple, yet vital, as encouraging regular screening for yourself and the loved ones in your life. Your informed action, however small it feels, can genuinely make a real difference in tackling this global health challenge. And that brings us to the end of another deep dive here on vpod.ai. Thank you so much for joining us on this exploration today. We really appreciate you investing your time with us. And remember, for your enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, that turnkey security appliance, and public or private cloud needs, our sponsor Stonefly has solutions. Don't forget to check out their special offer. A 100 TB immutable and air-gapped SSO NAS for just $8,995. You can find out much more at stonefly.com. We look forward to our next deep dive with you.